Success on the hematology boards requires looking at a tangled mess of lab values and clinical signs to synthesize a diagnosis in real time. This framework is your baseline algorithm. Whenever a vignette presents a patient with cytopenias and circulating blasts, you need to act. The hypercellular marrow space on the right shows the mechanical reality. Malignant blasts are physically crowding out the production of normal red blood cells and platelets. To build diagnostic confidence, we are going to deconstruct 5 complex leukemia vignettes step by step. In this first scenario, a 28-year-old woman presents with severe bleeding. Notice the white blood count is 17,000, and the platelets are dangerously low at 13,000. Her coagulation studies show low fibrinogen and elevated PT and PTT, indicating disseminated intravascular coagulation. We can eliminate distractors quickly. With a platelet count of 13,000 and active DIC, we have progressed beyond a simple von Willebrand disease presentation. Leukapheresis is also incorrect. That intervention is generally reserved for white counts exceeding 100,000 to manage hyperviscosity. The peripheral smear provides the definitive evidence. We see bilobed blasts packed with dense granules, known as Auer rods. This morphology, combined with DIC and pancytopenia, identifies acute promyelocytic leukemia, or APL. The correct answer is D. This establishes a critical management principle. Never wait for genetic confirmation of the PML-RARA fusion to treat APL. Because the bleeding risk is lethal, you must start all trans-retinoic acid the moment you suspect the diagnosis. Now consider a post-remission decision. A 40-year-old man in complete remission from AML needs a choice between high-dose cytarabine and a stem cell transplant. The decision rests entirely on his genetic profile. Allogeneic transplant carries significant morbidity, so we reserve it for high-risk disease. We can cross out a monosomal karyotype, like -5 or -7, a TP53 mutation, and a KM2A rearrangement. These profiles indicate a high risk of relapse that mandates a transplant. That leaves us with option C. This highlights our second principle. Patients with a favorable risk profile, such as an NPM1 mutation without a FLT3 ITD mutation, are managed with chemotherapy. We consolidate them with high-dose cytarabine and spare them the transplant. This third scenario describes a 67-year-old patient with known chronic myeloid leukemia presenting with progressive fatigue. The lab results show 15% blasts in the marrow and 22% basophils in the peripheral blood. Pause the video here. Before we proceed, commit to the exact blast thresholds that separate the different phases of CML. This timeline maps out the WHO criteria. Chronic phase CML involves fewer than 10% blasts. Once a patient reaches 10 to 19% blasts or hits 20% basophils, they have entered the accelerated phase. Anything at or above 20% blasts is defined as blast phase. Because this patient is in the accelerated phase, standard induction chemotherapy is the wrong choice. The correct answer is B. Accelerated CML requires an immediate pivot to a second-generation tyrosine kinase inhibitor and a referral for an allogeneic stem cell transplant. Next, evaluate this 65-year-old functionally independent female, newly diagnosed with Philadelphia chromosome-positive B-cell ALL. The regimen must be tailored to her fitness level. A pediatric-inspired regimen is too toxic for a 65-year-old. However, because she is independent and has no major comorbidities, supportive care or a steroids-only approach is inappropriate nihilistic. The correct answer is dasatinib plus hyper-CVAD. This reinforces our fourth principle. While the intensity of the chemotherapy backbone is dictated by patient fitness, the targeted TKI is mandatory from day one. The most difficult board questions require recognizing when an indolent disease abruptly transforms into an aggressive one. A 47-year-old patient with a history of chronic lymphocytic leukemia suddenly develops rapid asymmetric lymph node growth and hypercalcemia. Her PET scan shows a node with an SUV of 24, and a core biopsy confirms diffuse large B-cell lymphoma. You will see highly effective standard CLL therapies listed as options, such as ibrutinib or venetoclax. Choosing these here is a diagnostic error. The asymmetric growth, the elevated SUV, and the new biopsy results confirm Richter's transformation. The CLL has transformed into an aggressive lymphoma. You must immediately pivot away from CLL drugs to an aggressive regimen like R-CHOP. We have deconstructed 5 distinct pathways. To summarize, Start APL treatment before the genetics return. Consolidate favorable risk AML with chemotherapy, not transplant. Pivot to second-generation TKIs for accelerated CML. Always include a TKI for Philadelphia-positive ALL. And for Richter's transformation, move directly to aggressive lymphoma protocols. Use this checklist to navigate the hardest vignettes on your exam.